Assalamualaikum.
Waalaikumsalam, Doktor.
Assalamualaikum.
Salam.
Okay, saya start dengan Fatihah lah. Okay, boleh start lah.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. To Dr. Alwi, my fellow friends, thank you, Doctor, for spending your time this morning to be our supervisor. So, this is a case-based MENA 4, and there will be 4 subtopic that we will discuss today. Okay, so the first topic is on the floppy infant. So I am Ahmad Najahan bin Ali with metric number 1716545. So the meaning of floppy generally can be understood as hypotonia or weakness. Floppy infant means generalized hypotonia with or without limb weakness. So the hypotonia here means there is a diminished resistance of muscle to passive stretching. While weakness here means decreased ability to move muscle activity and voluntarily. The cause of hypotonia can be generally divided into central and peripheral causes. We suspect central causes when the infant has an upper motor sign and they are relatively stronger compared to the peripheral causes. In peripheral causes, usually they will manifest a lower motor neuron sign, and they are generally weaker than central causes. So for the central causes, it can be further divided into two, which is the brain and spinal cord pathology. So in general, genetic and chromosomal abnormality contribute around 30% of floppy infant. Example of genetic abnormality presented with floppy infant is Down syndrome and Prader-Willi syndrome, followed by so the other causes is of floppy infant is hypoxic ischemic encephalopathy. So in peripheral causes, it can be further divided into anterior horn disorder, neuromuscular junction disease, muscle disorder, and peripheral nerve disorder, such as in acute post-infection in Guillain-Barré syndrome. So this is to make us easier to understand the causes based on anatomical region. So from the history, usually the presenting complaint will be the decrease in tone, where we can feel the hypotonia when we picking up the infant. They tend to slip through our fingers and hang like a rag doll when we suspended prone. Some of them may have difficulty in sucking and chewing. They have a weak cry, decreased movement, delayed motor milestone, and some of them may have a floppy larynx, which can presented with breathing difficulty and recurrent chest infection. We also need to know the onset of the complaint as well, either to know either it is a congenital problem or acquired problem, and also the progression of the disease, of the symptom. Birth history is important in assessing hypotonic infant. Antenatally, we need to ask about the quality and frequency of the fetal movement, baby presentation, especially back presentation, because back presentation predisposed for cord trauma, history of maternal infection, and history of maternal infection. We also need to ask about either the child was born term or not, any complication during the delivery, and any history of birth anorexia, such as a cord prolapse. Meanwhile, other than that, history of low cord pH and low Apgar score and neonatization might indicate the child might have a HIE, which is one of the causes of floppy infant. Other than that, some of the disease is genetical in nature, so we need to ask the history of neuromuscular disease in the family. Okay. For physical examination, the most important part is the neurological examination, the upper and lower limb. So from the physical examination, we need to differentiate either the causes it is because of either it is central or peripheral causes. As I mentioned earlier, central causes they are usually presented with upper motor neuron sign, and peripheral causes presented with lower motor neuron signs such as hypotonia and hyperreflexia. And generally, peripheral causes their weakness are more prominent than central. Okay. Apart from the neurological examination, on general examination, we need to see the mental status of the patient, the cuff test. Usually, in a normal child, they only need one cuff to to secrete the secretion, while in the weak child, they usually need more than one cuff to secrete the secretion from their airway. Also, if there is any drooling, which might indicate that the child may have a poor swallowing, cry quality might indicate the child have a respiratory weakness, and their posture and any sign of dysmorphism. Okay. Apart from the upper and lower limb examination, we also need to do a full cranial nerve examination. And the third part of the physical examination is the hypotonia evaluation. So, so in hypotonia evaluation, on general examination, we will see the posture of the child is like a frog-like posture, and on vertical suspension, their knee will be hanging and scissoring, whereas in a normal child, their knee and feet will be flexed when we pick up the child vertically. Okay. As a picture here. And next evaluation is horizontal suspension. They will behave like a ragdoll when we you can see there is a hanging of their limb and the upper and lower limb. And finally is the traction response. There will be an extreme head lag. Okay. So the initial approach to a floppy infant, as I mentioned, is to determine whether the problem is central or peripheral. Because this is crucial when forming a plan for diagnostic investigation. So we can distinguish the origin clinically. Central hypotonia is associated with poor truncal or axial tone, but preserved limb tone. Lower motor neuron lesion is suggested by frog-like posture, poor anti-gravity movement, and hyporeflexia. This is an algorithm on investigation when approaching a floppy infant. I get it from a Nielsen Essential of Pediatric textbook. So first thing first is distinguish the origin, central or peripheral. If central, look for any dysmorphic feature. If there is a dysmorphic feature, it is suggestive a genetic causes. So in this case, we do a karyotyping. So then we can get the diagnosis either Down syndrome or Prader-Willi syndrome. And there is no
What is CMS? Huh? Sorry,
yes,
what is CMS?
chromosomal microarray analysis, microarray
Okay.
analysis.
Okay. Thank
If there is no dysmorphic feature, proceed the brain MRI to see any. So we want to see any the other causes of floppy infant. For example, as I mentioned earlier, is a HIE. So we need to look any evidence of HIE in the brain MRI. For peripheral causes, we can do a creatine kinase, acid creatine kinase, and others. So I think this is another algorithm. I think this is more easy to understand. Okay. So the principal management or principal treatment of floppy infant is firstly is to treat the underlying causes. Other than that, we can also offer the physiotherapy in order to prevent any contracture, occupational therapy to improve the posture and function. Patient with difficulty in breathing, we give respiratory support. For nutritional support, we insert nasogastric tube and provide caloric supplementation in baby with low weight and advice on prophylaxis vaccination such as influenza and pneumococcal. And last but not least, offer a genetic counseling and psychological support. I think that's all for B. This is the reference.
Okay, got a question? Anyone? You will tell you presenter. You guys year 5 kan?
Yes, okay.
Okay, ada soalan? Sekejap eh. Next.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Y5B3, and now I will presenting about the infant who is jaundice. So next. So first of all, we move on to the definition of the jaundice. So based on Nelson textbook, jaundice is yellowish discoloration of sclera, skin and mucous membrane due to elevation of serum bilirubin. And then, however, jaundice is clinically detectable when the serum bilirubin level are more than 85 micromole per liter or 5 milligram per deciliter. Next. So these are the picture of bilirubin metabolism. However, I will not explain about this because we had already seminar explaining the bilirubin metabolism. Next. And then I would like to explain the physiological jaundice, in which it happened due to the excessive bilirubin production due to higher hemoglobin content and also shorter red blood cell lifespan compared to the adult red blood cell lifespan, and also second due to the poor bilirubin clearance due to the liver immaturity. And then physiological jaundice usually appears 2 to 4 days after birth and resolving after 1 to 2 weeks. If the baby is preterm, it's resolved during the 3 weeks, and it is not associated with underlying disease and it is usually benign. Next. So this is the causes of the neonatal jaundice. This divided into according to the onset of the jaundice. So the first is jaundice starting less than 24 hours of age, in which it's commonly due to the hemolytic disorder such as resus incompatibility, ABO incompatibility, especially in mother with blood group O. And then G6PD deficiency, another is spherocytosis, pyruvate kinase deficiency. Other than that is can cause also by congenital infections. So second one is jaundice that occurred between 24 hours to 2 weeks of age. So this is common to happen due to the physiological jaundice. And then another one is breast milk jaundice, in which in breast milk jaundice it is however is more common in prolonged jaundice. This is due to the presence of the beta glucuronidase in milk, in which it will deconjugate the bilirubin in the infant's intestine, and then it will increase the enterohepatic circulation of the bilirubin. And then another differential is we can think of is infection, in which we need to consider the UTI. Other than that, also can be due to hemolysis, such as G6PD, ABO incompatibility. Other than that, bruising, polycythemia, and Crigler-Najjar syndrome, in which deficiency or absence of the glucuronil transferase that convert the unconjugated bilirubin to the conjugated bilirubin. The last one is jaundice that occurred more than 2 weeks of age. In here, divided into the unconjugated hyperbilirubinemia and also conjugated hyperbilirubinemia. So for the unconjugated, it can be due to the septicemia, UTI, breast milk jaundice, which is the commonest one in prolonged jaundice. And then that hypothyroidism and also hemolytic disorder, and also Gilbert syndrome and galactosemia. For conjugated hyperbilirubinemia, it is suggested in which the baby will passing out dark urine and also unpigmented pale stool. So in conjugated hyperbilirubinemia, it is important for us to exclude the biliary atresia, as it is can affect the outcome of the infants. Other than that, this the other differential diagnosis of the conjugated hyperbilirubinemia more than 2 weeks of age. Next, the first one is we need to get the history for the presented illness for the infant with jaundice. First, we need to ask about the onset of jaundice, in which we can get idea based on the differential diagnosis that I have explained before. And then we can ask the feeding, in which if infant have poor feeding, they can get breastfeeding jaundice, which is different from the breast milk feeding. In breast milk feeding, the breast milk feeding, there is no abnormality due to the breastfeeding because the infant breastfeed normally. And then we need to ask either the infant have difficulty during feeding and not get enough breast milk, which can lead to breastfeeding failure jaundice. Other than that, we can ask about waking or for feeding, looking hungry, or coming, latching, number of feeding in last 24 hours. Basically, we need to ask the assessment of the breastfeeding to the mother. Other than that, we need to ask about the pathology. For example, in the change of diaper, and then change of meconium to yellow and CD stool. Also mental status, because severe hyperbilirubinemia can lead to connectivus. And then we can ask about the amnia, seizure due to acute bilirubin encephalopathy. And then ask about lethargy or poor feeding due to the severe hyperbilirubinemia. So at the right side, we can see this is the risk factor for infant to develop severe neonatal jaundice, which the first one is prematurity. And then we can ask about the birth weight of the baby. And then jaundice in the first 24 hours of life, and then mother with blood group O or rhesus negative, and then about the G6PD deficiency, and also other than that, we can ask anything related to the risk factor. For example, cephalohematoma, we can ask either is any abnormality of the infant head or the history of instrumental delivery. Next. So for the physical examination, for general condition, we need to assess the weight because the weight can be affected due to prolonged jaundice due to a certain disease, and then sign of sepsis. And then we need to look for the dysmorphic feature, for example, in Alagille syndrome, in which we can note that the infant may have both forehead, pointed chin, and deep set and widely spaced eyes. And then we need to assess for the hydration status, because in dehydrated patient, it can exacerbate the jaundice. And then we need to look for the sign of acute bilirubin encephalopathy, ABE, and in which we assess it by using the BIND score, which I will explain later. And then other clinical sign that we can see is that pallor, plethora, cephalohematoma, such in the picture below, and then subaponeurotic hemorrhage. And then we can also look for the sign of intra-uterine infection, such as petechiae and also hepatosplenomegaly. And then we need to assess the cephalocaudal progression for the severity of the jaundice. Next. This is the bilirubin-induced neurologic dysfunction score, BINDS, in which we assess the infants based on these three components: mental status, muscle tone, and also cry pattern. After that, we have get the score. So we need interpretation of the result based on the right table, in which score between 7 to 9 indicates the infant have advanced ABE, in which urgent bilirubin reduction intervention is needed to prevent further brain damage and also reduce the severity of sequelae. If the score between 4 to 6, it indicates that the infant have moderate ABE, in which urgent bilirubin reduction intervention is likely to reverse this acute damage. If the score is just between the 1 and also 3, it indicates mild ABE, in which the signs is just subtle. Next. So this the visual assessment of neonatal jaundice, Kramer's rule, in which we assess the extent of the jaundice that developed throughout the infant body. So in fact, that the jaundice tend to start on the head and face, and then spread down to the trunk and limbs. So if the baby is clinically jaundiced, as you can see visually by looking at the neonates, if the jaundice already extend to the palm or soil, it already indicate that the severity of jaundice is already at the level 5, which is severe hyperbilirubinemia. Just remember that if the jaundice extend to the peripheral part, it already more severe. So if the bilirubin is clinically jaundiced, the bilirubin should be checked with a transcutaneous bilirubin meter or blood sample. Next. So this is another investigation other than visualizations, which are the transcutaneous bilirubin (TCB) and also total serum bilirubin (TSB). So TCB should be used if jaundice is detected, especially by visualization. This is because transcutaneous bilirubin is more accurate than visual assessment in detecting hyperbilirubinemia, in babies more than 34 weeks. This is because some patients have darker skin than the other baby, in which the healthcare practitioner may underestimate the extent of the jaundice. Then if transcutaneous bilirubin level exceed 200 micromole per liter, total serum bilirubin should be measured. Total serum bilirubin also is it should be measured in baby with jaundice if the transcutaneous bilirubin is not available. Please to note that the transcutaneous bilirubin should not be used to monitor bilirubin level in babies on phototherapy. Next. So this another investigation which is specific to the underlying causes. So in babies with severe hyperbilirubinemia, early onset neonatal jaundice, which is less than 24 hours, or rapid rise of total serum bilirubin more than 8.5 micromole per liter per hour, further laboratory evaluation may be required to ascertain the underlying causes and extent of hemolysis. As I have explained before, the hemolytic disorder is the most common one that cause jaundice less than 24 hours of life. So these are the several investigations that can be done to find the underlying causes. For example, G6PD testing if the infant have not been screened before, and then we need to get for mother and baby's blood group. Also, we can do direct scope test, for example, in ABO incompatibility. And then we can do full blood count and also peripheral blood picture, for example, in hemolytic disorder like G6PD deficiency. Other than that, we can do reticulocyte count and also septic workup if we suspected for congenital infection. So all babies should be screened for G6PD deficiency. So the result should be reviewed within 24 hours. So G6PD enzyme assay must be considered in babies which is suspected. So we suspected to have jaundice less than 24 hours. Next. So these are the flow charts of management for the neonatal jaundice. As you can see, first we need to assess the baby for risk factor as listed at the right side. As you can see, for maternal, for the ABO incompatibility, especially the blood group O, and then results negative, and then red cell antibodies followed by others. And then for neonatal, the risk factor is including the feeding, breastfeed, or also reduced or poor breastfeeding. And then hematoma or bruising, polycythemia, hemolysis, bowel obstruction, and also infection. And then after we have find the risk factor, we do the assessment for the jaundice, especially by visualization and also transcutaneous bilirubinometer. So if the baby appears jaundice, if yes, we need to identify the age of onset based on the differential diagnosis that have been explained before. So for the below the 24 hours of age, it is considered a medical emergency. So these are the further management that will need to be done. And then for the management of the jaundice, if conjugated bilirubin elevated, we need to urgent liver function test and also R&R, and then refer to pediatric surgeon or gastroenterologist. So then we need to plot total serum bilirubin on nomogram, and then and also for the monitor during the phototherapy. So at the right side is the indication for referral to the hospital. For example, jaundice within 24 hours of life, which considered as medical emergency. And then jaundice that below umbilicus, which indicate correspond to more than serum bilirubin more than 200 micromole per liter, and then jaundice extending to the sole of feet, which is already considered severe at the level 5, and then family history of significant hemolytic disease or kernicterus. Other than that, any unwell infant with jaundice, also prolonged jaundice of more than 2 weeks. Then the infants with conjugated hyperbilirubinemia should be referred to a hospital as soon as possible. Because conjugated hyperbilirubinemia is important for us to exclude the biliary atresia. And then lastly, infant with unconjugated hyperbilirubinemia can be investigated and referred only if the jaundice does not resolve or a definitive cause found. Next. So these are the option of treatments for the jaundice. So phototherapy is the best mainstay of treatment for the infant with jaundice, as it can reduce the infant for going exchange transfusion. So the effective phototherapy, it can be optimal irradiance and adequately exposed body surface area rather than the number of phototherapy units. So the goal of the phototherapy is to prevent neurotoxicity related to indirect reacting bilirubin. So the complication that may arise from the phototherapy is the first one, loose stool, and then erythematous macular rash, purpurine rash, and associated with transient porphyrinemia, overheating, dehydration, hypothermia from exposure, and also Brown's baby syndromes. And phototherapy is contraindicated in porphyria. So the things they need to note that overhead phototherapy is superior to the underneath phototherapy. This is because duration of phototherapy overhead is shorter, and the rate of decrease in total serum bilirubin is more rapid in overhead compared to underneath LED. So supine position is the best position for the baby undergo phototherapy and with adequate exposure. However, we need to cover the infant's eye. And then started at lower threshold in preterm and low birth weight babies. And then LED is preferred in preterm babies. And then visual observation as a mean of monitoring is unreliable. So just as I have said before, serum bilirubin level is the indicator for the monitoring for the patient that undergo phototherapy. So next is the exchange transfusion, in which exchange transfusion is required if the bilirubin rise to the level they are considered potentially dangerous. So in this procedure, blood is removed from the baby in small aliquots, usually from an arterial line or the umbilical vein, and replaced with donor blood. So usually we use double volume exchange, in which the double volume exchange include we double the blood of the baby to be exchanged. And then we need to use the freshest blood available, procured within 3 to 5 days for the double volume exchange. If the whole blood is not available, we can use a combination of fresh frozen plasma and packed red blood cell with ratio of 3 to 1. So the complication that may arise from the exchange transfusion, the first one is catheter related, in which we can cause infection, hemorrhage, and also necrotizing enterocolitis. Then that it can cause hemodynamic problems such as overload cardiac failure, hypovolemic shock, and arrhythmia. Other than that, it can cause electrolyte or metabolic disorders such as hyperkalemia, hypocalcemia, hypoglycemia, or hyperglycemia. Next. So this is the example of nomogram. So this graph is for the management for baby greater than 38 weeks gestation. So there's a several graph that have been used according to the patient gestation weeks, and also the weight of the infants during the birth. As you can see, the exchange transfusion threshold is a bit higher than the phototherapy total serum bilirubin threshold. So by using the phototherapy, we can reduce the number of the infant with jaundice to undergo exchange transfusion. We can lead to severe complications. So there is no specific duration based on phototherapy. However, it's basically based on the level of TSB. Which we need to monitor frequently to see if the level of the total serum bilirubin is going down below the phototherapy threshold, so that we can stop the treatment on phototherapy. Next. So I think that's all for my part. Thank you.
Assalamualaikum. I have a question. Is
Hi.
acute bilirubin encephalopathy similar to chronic teres?
From what I have read, chronic teres can cause acute and also chronic bilirubin. Acute and chronic bilirubin encephalopathy are considered chronic teres.
So it is an irreversible condition.
Irreversible. I'm not sure.
Thank you.
So connectivity is the extreme end. Okay. Usually patient with connectivity, they presented with seizure. Once they've got seizure, then it's connectivity lah. All the sign prior to connectivity like high pitching cry, episotonous position, things like that. These are all the preceding sign before connectivity. Okay, any other questions?
Thank you, Doctor.
Once connectivity, then it's gone lah. You know you're going to have a CP baby. Okay, next. Make it shorter, make your presentation shorter.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Can everyone hear my voice?
Yes.
Yes, okay, thank you. Okay, and next, I'm Nabila. We proceed with a child with multiple bruises. Next. Okay, a bruise or ecchymosis is caused by bleeding beneath the skin as a result of extravasation of the blood from surrounding blood vessels. Petechiae is a pinpoint, non-branching lesion less than 2 mm in size, while purpura is a group of adjoining petechiae that measure greater than 2 mm. And the hematoma is a solid swelling of the clotted blood within the body's tissues. Okay, next. So these are the pictures of the petechiae, purpura, and ecchymosis. We can see that there are differences in the size. Okay, next. Okay, before I go further with the child with multiple bruises, let's go briefly recap on the hemostasis of the blood clotting. There are two parts, which are primary hemostasis and the secondary hemostasis. For the primary hemostasis, the main component is the platelet, which the final result is the formation of the platelet plaque, while the secondary hemostasis, the main component is the clotting factors that been produced by the liver, and the final result is the formation of the stable fibrin clot. So if there's any defects in the platelet and the clotting factors, this will be cause increase in bleeding. Okay, next. Next, for the possible causes of the bleeding. Next, this list I got from the Nelson textbook. So the causes of bleeding, we can divide it into hematological and non-hematological. For the hematological, it could be due to thrombocytopenia and the coagulopathy. For the thrombocytopenia, for the primary causes are the immune thrombocytopenic purpura, or ITP, is the commonest cause of the thrombocytopenia in the childhood. It is caused by the destruction of the circulating platelets by the antiplatelet IgG autoantibodies. So the reduced platelet count in the ITP can be accompanied by a compensatory increase of the megakaryocyte in the bone marrow, which we can see in the full blood picture, the giant platelet cell. The other causes of the primary thrombocytopenia includes neonatal isoimmune, TAR syndrome, and the Wiskov-Aldrich syndrome. TAR syndrome, it is a thrombocytopenia absent radius syndrome. It is a rare disorder that present at the birth, which is congenital, and is characterized by the low level of platelet in the blood and absence of the long thin bones of the forearms. And for the secondary causes of thrombocytopenia, are malignancies such as acute lymphoblastic leukemia, aplastic anemia, disseminated intravascular coagulation, sepsis, and many more. For the coagulopathy, for the primary causes, von Willebrand disease. This disease is inherited as an autosomal dominant trait, and as we all know, von Willebrand factor is an adhesive protein that serves as two functions. The first function is as acting as a bridge between subendothelial collagens and platelets, while the second function is to protecting the circulating factor 8 from the rapid clearance from the circulations. So if there's any deficiency in the von Willebrand factors, it can result in a prolonged bleeding. For the hemophilia, such as hemophilia A and B, both actually is the X-linked recessive inheritance, and the other cause of primary coagulopathy is a platelet function defect. For the secondary causes are disseminated intravascular coagulation, anticoagulants, vitamin K deficiency. As we know, vitamin K is important in the production of the active forms of the factor 2, 7, 9, and 10. And the other causes are hepatic failure, renal failure, maternal anticonvulsant, and anticoagulant drug injection. Okay, for the non-hematological causes, which are child abuse, vasculitis, other trauma, ulcer, varices, polyps, tumor, Ehlers-Danlos syndrome, telangiectasia, and angiodysplasia. For the Ehlers-Danlos syndrome, it is a group of inherited disorder that affect connective tissue, primarily skin, joints, and blood vessels wall. So the bleeding that occur in this syndrome is actually due to the connective tissue disorder. It's not due to the clotting problems. Okay, next. Next, for the history of presenting illness, first we need to ask about the age of the onset of the bleeding, because it might tell us if it's inherited or acquired. For inherited bleeding disorder, it should be strongly considered if the onset of the bleeding occurs in infancy or early childhood, particularly if associated with the positive family history, for example, in hemophilia. For the gender, especially for the male gender, also highly suggestive of hemophilia, especially if the male infant who is starting to walk and presents with a painful swollen joint after a fall. We need to assume this child have hemophilia until proven otherwise. For the duration, if it's the bleeding occur acute or chronic. If it's acute, it might suggest for ITP. If it's chronic, it might suggest for the malignancy. For the site, if it involves skin or large joints, we need to ask the child if it have swollen and painful joints, which is common in hemophilia. For the bleeding severity, we need to assess the severity of the bleeding. If it is involve cutaneous bleeding, mucosal bleeds, or life-threatening bleeding, and the history of the bleeding. For the history of bleeding, if the bleeding into the skin or mucous membrane, it actually due to platelet disorder. Meanwhile, if the bleeding into the deep organs, into the deep tissues, muscles, and joints, it highly suggestive of the disorder of coagulation proteins. Next, we need to ask about history of easy bruising or bleeding, history of the trauma, and non-accidental injury or child abuse. For child abuse, we should be highly suspected for child abuse if the findings of the bruises is not correlate with the history that we take from the caretaker. Okay, next. Next, for the history of preceding viral infection, which is most likely for ITP. For the risk factor for HIV also can cause thrombocytopenia. For the drug history, certain drugs can impair platelet function and may exacerbate an underlying coagulation disorder. For example, aspirin, herbal medication, and NSAIDs. For the nutritional history, we need to ask if the child might have vitamin K deficiency. For the family history of bleeding disorder, if the gender of the affected relative is only male, suggest hemophilia. And for the systemic symptoms, such as fever, bone or joint pain, loss of appetite or weight loss, which suggests of malignancy. And the last one is the symptoms of intracranial hemorrhage, which are headache, persistent vomiting, altered mental status, and seizures, which indicate severe bleeding disorder. Okay, next. For the physical examination, general, we might want to look at the signs of anemia. For example, conjunctival pallor. You want to assess the oral cavity and the lymph adenopathy, which suggests of malignancy in the acute lymphoblastic leukemia. Next, we want to assess the appearance and distribution of the bruises. If the bruises appear on the trunk, back, or face, especially in the young pre-mobile infant, it should raise one suspicion of an underlying bleeding disorder or the possibility of the physical abuse. If the bruises related to normal physical activities, actually it tends to appear on the distal upper and lower extremities, especially in the active toddlers. In the children 1 to 3 years old, bruises are commonly found on the anterior tibia and knee, followed by upper legs and forehead as a result of falling from learning how to walk or run. Okay, next. We also need to see the other signs of the bleeding, such as a PTK, purpura hematrosis, which may indicate underlying blood disorder. Next, for the abdominal examination, we want to see the hepatosplenomegaly in the hematological malignancy or in chronic liver disease. And the last one, joint examination in the hypermobile joints or skin hyperelasticity that can be seen with the Ehlers-Danlos syndrome. Okay, next. Okay, for investigation, we might want to send a full blood count because it will help us in narrow down the diagnosis. If in the aplastic anemia, it can show the pancytopenia. If it's for immune thrombocytopenic purpura, the full blood count usually show isolated thrombocytopenia with normal hemoglobin and white cell count. For leukemia, usually have anemia, thrombocytopenia, and total white cell count can be normal, low, or high. For the peripheral blood film, you might want to see the platelet size, which is larger in the ITP, the presence of the blood cells in the acute lymphoblastic leukemia. Next, for the coagulation profile, especially in the hemophilia, in the hemophilia, usually the activated partial thromboplastic time, APTT, is prolonged, and the prothrombin time and the platelet count usually normal. And based on the pediatric protocol, when the APTT is prolonged, then we will proceed with the specific factor assay, which is factor 8 antigen level. If the factor 8 antigen level is normal, then we will proceed with factor 9 level. Okay. Next, the last one is the bone marrow examination if we suspect in acute lymphoblastic leukemia. Okay, last one for the management. For the management, it actually focus on the diagnosis. For the immune thrombocytopenic purpura, the first line we give IV immunoglobulin followed by oral prednisolone, and also if you want to give platelet transfusion if it's severe bleeding. For the hemophilia, we would like to replace the factor deficiency by factor 8 concentrate in the hemophilia A and the factor 9 concentrate in the hemophilia B. And want to give the supportive management, such as analgesia for pain relief in the hematosis, von Willebrand disease. Next. Okay, for the von Willebrand disease, we might want to give desmopressin is the treatment of choice for most bleeding episodes in patients with type 1 disease and some patients with type 2 disease, and also von Willebrand factor containing concentrate. Okay, I think that's all from me. Is there any questions?
Okay, any questions? That's quite a detailed management. You are not expected to know, but it's good to know lah. Like things like von Willebrand disease management. In general, we don't do anything for von Willebrand disease, except in severe bleeding, for example, accident ataupun elective surgery. But most of the time, they don't do anything. And remember, the most common cause of hemophilia is von Willebrand disease. Okay, next.
Okay, Bismillah. Assalamualaikum warahmatullahi wabarakatuh. My name is Wajiha and I'm going to talk about how we approach to a child who failed to drive. Next. So this is my outline of my presentation for today. Next. So before we go further, let us recall on the definition of the failure to drive. According to the Nelson textbook, FTT is defined as reduction of weight or height of a child by 2 or more centiles plotted on the growth chart, or when the growth parameter is persistently below the 3rd centile. And for the WHO chart, FTT occurs when the growth parameter is below the 2 standard deviation of the mean age. And please bear in mind that FTT is not a diagnosis, rather it is a sign of underlying disease that we need to dig further. Next slide. So in this slide, I provide you guys with 2 growth charts in which on the left side, we can see that the weight of the child is persistently below the 3rd centile, started at the age of 7 months old, while as for the length, as for his length, it crossed...
Can you go to previous slides? I terkeluar pula tiba-tiba.
Okay, Dr. Ken.
Okay, this one.
So this is the definition for failure to drive, in which FTT is defined as reduction of weight or height of a child by 2 or more centiles plotted on the growth chart, or when the growth parameter is persistently below the 3rd centile. And for the WHO chart, failure to drive occurs when the growth parameter is below the 2 standard deviation of the mean age. And FTT is not a diagnosis, rather it is a sign of underlying disease that we need to dig further. So this is the growth chart showing you on the left side. We see that the weight of this child is persistently below the 3rd centile. And for his length, it crossed 2 centiles between the age of 3 months old to 15 months old. Next, if you see the WHO chart provided on your right side, if the child growth parameter is plotted within the yellow area and below, it indicates that the child is failed to drive. Next slide. So there are actually a few ways for us to classify the cause of the condition. According to the Nelson textbook, they classify the cause into several categories, which include the environmental, which is the most common one, gastrointestinal, congenital, infection, metabolic, neurology, renal, and also hematology. I believe this is quite an extensive number of causes that we need to take into account. Hence, another way to classify the cause of FTT is that we can divide into organic and inorganic cause. For the organic cause, it means that patient has underlying medical disease that lead to the FET. For example, patient has inadequate food intake due to feeding difficulty. For example, in patient who have cleft palate or cerebral palsy, or patient has diminished food absorption, meaning they can feed properly, but they cannot absorb the nutrition, such as in patient who has cystic fibrosis or celiac disease. Next is patient who has increased energy requirement, for example, child who have malignancy or thyrotoxicosis. And last but not least is chromosomal abnormality, such as in Down syndrome, Noonan, or Turner. For the inorganic cause, meaning patient has no known medical illness. It includes feeding problems such as inadequate breast milk or patient who is raised in an environmental deprivation. Next is about the history taking. For the history taking, we need to assess assess the patient's developmental history, as patient with FPT may have developmental delay. We also need to assess if the patient has symptoms of complication of poor feeding, such as constipation, lethargy, and becomes easily irritable. Not only that, an extensive systemic review needs to be done in order to enable us to know which system is affected that lead to this child to have FPT. For example, if the child is having chronic cough with history of recurrent pneumonia, and associated with chronic diarrhea, this may indicate that the patient is suffering from cystic fibrosis. Next is birth history. History of IUGR, prematurity, low birth weight, and exposure to smoking and alcohol are some of the risk factors that may lead to the failure to thrive later on. For the past medical history, we need to ask about the number of previous hospitalization. This may indicate chronic medical illnesses. And not to forget, the most important part of history is the feeding history, in which we need to know not only about the quantity of the food, but also the quality of the food. Ask further about the weaning process, since most child will have failure to thrive at this point in their life. Family history is also important to exclude any familial short stature by asking for the maternal and paternal height, as well as the growth of other family members. Last but not least is the social history, which is very important since parental depression, marital disharmony, food shortage, and poverty may lead to the inorganic cause of failure to thrive. Next is the physical examination. So a complete physical examination and developmental screening should be done, which includes general ones. We look for any dysmorphic features, signs of malnutrition, evidence of neglected hygiene, or signs of abuse. And look at the color of the patient. If it's pale because of anemia, peripherally look for any clubbing due to chronic hypoxia. Is there any peripheral edema due to protein deficiency? Is there any oropharyngeal lesion that lead that may interfere with their feeding? For the anthropometric history examination, we need to know the weight, the height, the head circumference, the mid-arm circumference to look for the skeletal muscle mass, tricep skin fold thickness, look for the subcutaneous fat storage. For the vital signs, patient may have hypertension because of renal disease or thyroid disease. Patient may have tachycardia or tachypnea because of the increased metabolic demand. Next slide. For the respiratory history, patient may have wheezing, crepitations, prolonged expiratory phase, or hyperexpansion due to the cystic fibrosis or asthma. For the cardiovascular examination, look for murmur in patients who have congenital or acquired heart disease. For CNS examination, look for is there any abnormal deep tender reflex, spasticity in patient who has cerebral palsy. For abdominal examination, look for any abdominal distension, hyperactive bowel because of the malabsorption. Also look for any organomegaly, such as in patients who have liver disease, glycogen storage disease, or even malignancy. Next slide. So for me, history and physical examination findings should guide us with the laboratory evaluation. Routine extensive lab and radio studies are not usually indicated for patient who has FTT, but rather tests should be ordered based on the findings of our clinical evaluation. Next slide. So I divide the investigation into the blood investigation, stool and urine, and also others. For the blood, we may want to order for full blood count to see if the hemoglobin, if patient have iron deficiency anemia. Look for the total white blood cell if there is increment due to infection or chronic inflammation. Order for renal profile to see if there any chronic renal failure, liver function test if patient have liver disease or chronic viral hepatitis. Thyroid function test if patient have hyperthyroidism that lead to increase in the metabolic demand. Next slide. For the urine, we can order for urine FEME and culture sensitivity for urinary tract infection. If we suspect patient to have worm and parasitic infection, we may order for routine stool ova and also cyst. Next. Others may include the chest X-ray to look for any cardiopulmonary disease or chest X-ray plus sweat test for cystic fibrosis. We can order for lactate and pyruvate for inborn error of metabolism, karyotyping in patient who has Down syndrome or Turner syndrome, or HIV test for immunodeficiency patient. Next slide. So the management of a child with failure to thrive includes, number one, is the correction of the underlying etiology, if it is possible. Number two is the nutritional management, which is the cornerstone of the treatment. Children with failure to thrive who are anorexic and picky eaters, they may require calories-dense food. For formula fed infant, maybe we need to do some correction on the formula appropriately. For the toddler, dietary changes should include increasing the caloric density of their favorite food. And last but not least, if the patient is severely malnourished, we may need to admit the patient and start on the resuscitation protocol if it is indicated. So that's all from me. Thank you.
Thank you. Very good. Any questions? Hmm. Any questions? Guys, ada soalan?
Doktor, regarding failure to thrive tu, we need both weight dengan height for reduced by 2 cm ke any weight ke height?
What is the definition?
Weight and height.
Apa definition dia? Cuba you baca baik your definition. So weight and height kan? So what does it means actually? I mean, we don't actually use failure to thrive tau per se. Failure to thrive is not a diagnosis, it's just a description of someone. He just a failure to he failed to thrive. He failed to thrive. Just a description, but it's not a diagnosis. So it's ideally don't use failure to thrive. Because it doesn't tell you anything. Just say that you've got a child who is small. But rather you should use more specific words that describe the nutrition or describe the possible underlying problems. Things like stunting, obese, apa lagi? Wasting, underweight, ataupun or short stature. These are more self-explanatory rather than failure to thrive. Okay, ada soalan lain tak? Hello? Saya ada soalan lain tak? Soalan lain? Kau dengar tak saya cakap?
Boleh doktor. I think
Dengar, Doktor.
Dengar kan?
I believe there is none. No other question.
lah. Okay. Dah kan? Dah habis kan? 4.
yes.
Sudah.
Okay lah. So anyway, thank you for the presentation. Can you send me the slides? I think the slide is very good, especially the failure to thrive and the yang sebelum ni apa just now? Apa pula?
Child with multiple bruises.
Sebelum tu floppy infant kan? Floppy infant, jaundice dengan ni okay lah. It's okay lah, semua okay. Okay, boleh kita tanggung atas speaker Farah. Nanti I bagi marks. Remind me for the marks.
Alright, Doctor.
Okay, kita tanggung atas speaker Farah.
Thank you, Doctor.
Assalamualaikum warahmatullahi wabarakatuh.